Every physician assistant, physician, or dentist should become familiar with the anatomy of the thorax. In this presentation, we will include significant clinical correlations of the anatomy of the thorax, mediastinum, the heart, and lungs. The presentation is comprised of about 5 parts and should be watched over about an hour per session. Included in this presentation are pathologies such as empyema, pneumonia, lung abscess, collapsed lung or pneumothorax, insertion of a chest tube, and a discussion of pleural effusion. While each of these may not be totally applicable to your profession, it's important to have a basic understanding so that you'll be able to communicate with your colleagues. Welcome to this presentation on Clinical Anatomy of the Thorax, Part 1. Here we will begin the review of the anatomy and the compartments of the mediastinum. This is a very lengthy presentation which includes not only a review of the anatomy of the thoracic cavity, but links to multiple videos re-emphasizing the clinically necessary thoracic anatomy. In addition, there are several attachments to be read and can be found under the paperclip icon in the Adobe Presenter file. Please download them separately, but I caution you not to read all of these at one sitting. This presentation, because it entails not only clinical anatomy, but videos, an explanation of pneumothorax, pleural effusion, empyema, and many other pleural pathologies, should be watched over several days, and I would expect you to watch this presentation over 3 to 4 days and review selectively those attachments which have been connected to this Adobe Presenter file. There's a lot of information here. Don't feel like you have to learn it overnight. I expect you at the conclusion of this presentation to be able to describe the gross anatomy of the thoracic cavity, which you will soon learn includes not only the pleura, the lungs, the mediastinum, the heart, and the diaphragm, but it also includes the thymus and the esophagus, as well as the vertebral column in the posterior mediastinum. You will also be held responsible to label a cross-section of the thoracic cavity as seen on CT scan, MRI scanning, or on a cadaver. It's best that you learn this cross-sectional anatomy by reviewing several of the images from VH Dissector. Also, I'll expect you to understand and explain the anatomy and pathophysiology of pleural effusions, what they are, how they form, how they're diagnosed, and how they're treated. Once you've understood how a pleural effusion forms and it's treated, you'll be able to better understand what a pleurodesis is and what a VATS is, also known as a video-assisted thoracic surgery. In addition, I'll expect you to understand and explain the pathophysiology of chylothorax. You'll also be able to compare and contrast a transudate and an exudate, and explain the technique and list the equipment necessary and several of the complications possible of performing a thoracentesis. This is a common procedure performed all over America every day to treat a pleural effusion, and you'll need to be familiar with it and watch the enclosed video from the New England Journal of Medicine. You'll also need to be able to explain what a pneumothorax is, how it's treated, and what the physiology of a pneumothorax compared to a tension pneumothorax is. Continuing, we'll need to be able to understand what a pleural space infection is and list the most common bacterial causes of a pleural space infection. You'll also need to be able to cite examples and describe the pathophysiology of a parapneumonic effusion and list a common condition in the abdomen which is most closely associated with the formation of a parapneumonic effusion. You'll also need to understand what an empyema is and how that differs from a lung abscess. Of the compartments of the mediastinum. The next several slides cover the various compartments of the mediastinum, and some of this you may have had in other presentations, or you'll get even later in presentations of the heart and or the circulatory system. If so, consider this an introduction or a review, depending on which side of the textbook you've already read. If not, it will serve as a good introduction. How about a break of a couple of minutes before we go on? There's a lot here. Hopefully you had a nice break. Now let's review what you already have seen and probably know. Here we have the thoracic cavity. We have a right pleural cavity and a left pleural cavity. The superior mediastinum, where the great vessels arch into the neck, which will include the brachiocephalic arteries, the carotid arteries, and the subclavian arteries. The inferior mediastinum houses the heart, and of course, the thoracic outlet, which is harbored by the diaphragm. Very basic, very simple diagram, but very important, as each area can be affected by different pathologies. On a lateral chest x-ray, you can identify most of this. You'll be able to see the thoracic column. Of course, you'll be able to see the heart, the costophrenic recesses in the posterior mediastinum, the superior mediastinum where the arch of the aorta is, the anterior mediastinum which houses the thymus and sometimes pericardial fat, and of course, in the posterior mediastinum is the esophagus. There is, of course, where the trachea comes through the thoracic inlet. There's a cervical portion of the trachea and a thoracic portion which lies in the superior mediastinum. The thoracic inlet combined with the superior mediastinum, the anterior mediastinum, the middle and posterior mediastinums can all be recognized on a lateral chest x-ray. Each of these contains different organs and can be affected by different tumors and different pathologies, and the physiology is different. Two pleural cavities will act physiologically different than the heart in the middle mediastinum. Realistically, this is the most important view. In the anterior mediastinum, a substernal goiter from an enlarged thyroid can lie here. Also the thymus gland, which in adults is usually involuted. The sternum. What if your patient is in a car accident and crushes their sternum? Can they get a cardiac contusion? What about an esophageal perforation in the posterior mediastinum? What about the pleural cavities? It's all related. In this picture, all of these areas and the important ones are labeled and circled. Anterior mediastinum, middle mediastinum, posterior mediastinum. The posterior mediastinum contains the descending aorta as well as the esophagus and of course the sympathetic chain ganglia. This is probably the most important picture of the mediastinum and its relationship to the pleural cavities and to each other. Let's look at this image from VH Dissector and, moving in a clockwise fashion, identify the anatomy. The right and left lungs are clearly labeled. The solid blue arrow is the superior vena cava. The solid red arrow is the arch of the aorta. The yellow arrow is one of the pulmonary trunk vessels. The white arrow shows the carina of the trachea. The red arrow, which is encircled in the white line, shows descending thoracic aorta. The green arrow, the esophagus, and the purple arrow is the azygous vein. You should be able to identify all of these structures on a cross-section of the thoracic anatomy. You'll probably see this image again. There's a tremendous amount of anatomy in this photograph too, but a lot of it's been stripped away just to show you the main structures. For example, the lungs are easily seen encapsulated by pleura. Remember, the visceral pleura is that which is on the organ itself. The parietal pleura here is retracted from the heart by pulling it medially away from the heart by clamps. You can see the thymus gland, which in adult is usually involuted. Of course, the superior vena cava is seen along with the left pulmonary artery. You can even see the ligamentum arteriosum, and you can see the vagus nerve wrapping around the arch of the aorta where it becomes the recurrent laryngeal nerve. Also, the internal jugular veins, which eventually join the left and right brachiocephalic veins, also known as the innominate veins. There's a tremendous amount of anatomy here, but if you understand the pleura and how the pleura wraps around the lungs and how the pleural space protects and surrounds the heart, which is encapsulated by the pericardial sac, you'll understand pneumothorax, empyema, pneumonia, pericardial tamponade, and a host of other diseases, including cardiac effusions from malignancies. The list goes on and on. This is an important picture. To take a 10 or 15 minute break before we review the skeleton of the thoracic cavity. You already know most of this anatomy. You know that there are generally 12 ribs. You know the manubrium and how it joins the body of the sternum at the sternal angle. The xiphoid process, which can be easily palpated, and the cartilaginous connections of the ribs to the sternum. The jugular notch will become important as an anatomical landmark, especially when placing central venous lines. We'll talk about central lines in just a minute. But of course, I really should ask, why do we care? For example, the jugular notch is anatomically important because that's where the very apex of the arch of the aorta is located. And if somebody is stabbed near the sternal angle, they're likely to injure the very large aorta coming off of the heart. Some of these anatomical landmarks aren't so obvious when we think of them as just the thoracic cavity alone. But if you think about what's behind these structures, it'll help you ascertain some of the pathology which you'll encounter in your clinical career. Notice how the ribs lie almost like the handle of a bucket. When one takes a deep breath, just like the handle of the bucket, the thoracic cavity will enlarge. It actually increases and lifts upward, just like the handle of the bucket lifting out. This is an important anatomical relationship to help you understand pulmonary disease. Here we can clearly see the costal cartilage and the costal margins, which are easily palpated. The jugular notch is seen laterally. Let's take a minute to look at the different ribs. We know the definition of true ribs. Those are ribs which join at the sternum. False ribs join the cartilaginous connections of the sternum but don't actually connect with the sternum. And of course, floating ribs posteriorly have no connection to the sternum at all. True, false, and floating. Why do we care? Because the spleen, for example, is located just between the false ribs and floating ribs posteriorly, and this protects that organ. Anteriorly, the liver is protected by false ribs in the right upper quadrant of the abdomen. Here's a summary of the anatomy which we have just looked at. True ribs, in other words ribs 1 through 7, join the sternum. False ribs 8 through 10 join the cartilaginous extensions of the sternum. And floating ribs 11 and 12 have no connection to the sternum. If you can understand the bucket handle analogy to how the rib cage expands and contracts with each expiration and inspiration, you need to understand how each rib articulates with the body of the vertebra. Here we can clearly see that the rib connects to the transverse process of a vertebral body. The spinal process is easily palpable. The shaft and body of the rib will actually move and expand laterally, just like the bucket handle analogy. And in order to do this, it depends on costal cartilage where it joins the sternum. Lots of ligaments join and attach the ribs to the body of the vertebra. Here we can see the costal tubercle of the rib being joined to the neck of the 8th rib through the costotransverse ligament. These are not particularly important that you memorize. Just understand that these ligamentous attachments allow movement of the ribs, and it's not fixed. This allows for safe and efficient respiratory motions, i.e. the movement of the bucket handle. You've heard of a flail chest and people who have had broken ribs. Do we fix them? Well, clinically, the answer is for most simple broken ribs, which are broken at one spot only, we usually don't fix those unless they cause respiratory compromise from undue pain. However, in a flail chest, where rib segments are broken at 2 different pieces from 2 different ribs, sometimes we fix these by plating these. Here's an image of this. A flail chest moves independently of the rest of the pleural cavity during breathing. There's a video coming up that shows this. And yes, you'll see this in your clinical career. Whether you're a trauma surgeon or not, you'll run into somebody that's had a flail chest, a chronic flail chest, or an unrepaired flail chest. And you'll need to understand how that affects the respiratory motion and efficiency. Here's a video which I have re-edited and linked to YouTube. It shows a flail chest in a patient who has had a traumatic injury and probably hit his chest on a steering wheel. It shows a chest tube in place laterally, and you can see as he breathes that the pulmonary excursions of the flail chest are opposite of the remainder of the lung. As he inhales and his chest normally expands, the flail segment, under negative intrathoracic pressure, caves in and moves in. And when he exhales and his thoracic cavity then collapses, the flail segment then expands. This is called paradoxical motion. Take a look at this video and listen to the commentary. Okay, there's a lot of anatomy on this slide, but let's point out what you really need to know clinically at this stage to understand the thoracic anatomy. We need to pay attention to the external thoracic wall, mostly the pectoralis major, the pectoralis minor muscles, and of course, laterally, we need to pay attention to the latissimus dorsi, the external oblique, the internal oblique, and even the serratus muscle. There are several structures which I've circled which need to be clinically relevant, and you need to make sense of them. For example, right next to the sternum and underneath the breastplate is the internal thoracic artery and vein, also known as the internal mammary artery and vein. Clinically, this is important because it's this artery which supplies blood not only to the intercostals, but to the sternum itself. It's a very important artery and it's used in cardiac bypass surgery. Once they open the sternum, the surgeon will dig out the internal thoracic artery and attach it to one of the coronary vessels when they're performing coronary artery surgery. The internal thoracic artery and vein, also known as the internal mammary artery and vein, continues downward on top of the abdomen where it forms the superior epigastric artery and vein. It's all one and the same. Now take a second and look at where the large red arrow is in the axilla. This anatomical structure is important, especially when we talk about breast cancer. Breast cancer is actually part of the thoracic cavity. Not only does it spread through lymph nodes in the peristernal region, but most commonly it spreads to lymph nodes in the axilla, which I've labeled with the triangle. The borders of this triangle include upwards towards the clavicle, the axillary vein, medially the chest wall, down to the sixth intercostal space, and laterally the latissimus dorsi muscle and the serratus anterior. It's in this triangle that the lymph nodes are removed when a woman or a man has breast cancer. When we perform an axillary dissection, this is where we take the lymph nodes from. Important nerves run in this area. Most importantly, the thoracodorsal nerve and the long thoracic nerve. We'll talk about those in just a minute. So let's review real quick why I'm even showing you this slide. The pectoralis major, the pectoralis minor, the breast tissue proper, the axilla, which is bounded by the axillary nerve, the latissimus dorsi muscle, the chest wall, the sixth intercostal space. We also need to remember the internal thoracic artery and vein, or the internal mammary artery and vein, and the superior epigastric artery and vein. Lots of anatomy, but it's all very important clinically when you start to examine patients. This slide shows us the accessory muscles of respiration. We'll see a video in the next slide of a child who is using all of these muscles to breathe as he presents with severe respiratory compromise. Numbers 1, 2, and 3 are the anterior, middle, and posterior scalenes. The anterior scalene is important because it has an odd relationship with the subclavian artery and vein. It runs right between these two structures. Why is this important? Because in a very thin person, perhaps someone with cancer or who has lost a lot of weight because of other disease, we can actually palpate the anterior scalene and where it separates the artery and vein, and that becomes necessary when you, as a clinician, will insert a central venous line. What is a central line? There's a video of that coming up too because it's important to the thoracic anatomy. Number 4, 5, and 6 represent muscles of the external intercostal, the internal intercostal, and the innermost intercostal. Number 7 is the transversus thoracis. It's an interior view. We'll see all of these muscles being used to help a child breathe. Let's take a look at that video. So before we show that video, let's take a look at the rib cage and how the muscles are located. Here I've circled the external intercostal membrane. If you note, the external intercostals actually don't go all the way to the sternum. And if you look at the previous slide, they do go all the way back towards the thoracic vertebra. Why is this important? Clinically, it's not. But when you put a chest tube in, you'll want to stay away from this membrane because underneath this membrane is the internal mammary artery and vein. Other accessory respiratory muscles include the subcostal muscles and, in the left on this figure, the transversus thoracis. The subcostal muscles usually span 2 or more rib segments, and the transversus thoracis, which is on the interior side of the sternum, as you can see in this image, is useful for severe respiratory distress as an accessory muscle. We'll take a look at the next slide, which shows a YouTube video of a child in severe respiratory distress. You'll be able to clearly see the subcostal muscles in action and impressively the transversus thoracis. Let's take a look. Put your Adobe Presenter on pause, click on the link above, and listen to the commentary I've recorded on the child in respiratory distress. You'll notice all of the muscles that he's using to breathe with: the transversus thoracis, the diaphragmatic excursion, the subcostals, the innermost intercostals, the external intercostal, the internal intercostal, even his scalenes. If you watch carefully, you can see almost all of these. Most impressive to me is the transversus thoracis. This video was taken from YouTube. It shows a child in obvious respiratory distress who is about to be mechanically ventilated. The respiratory therapist is getting ready, along with the physician, to intubate this patient and place a plastic tube into his trachea and breathe for him. Notice the anatomical accessory muscles of respiration. You can see the diaphragmatic excursion, the anterior scalenes, sternocleidomastoid muscle. You can also see the internal and external thoracic muscles. This video reinforces the importance of the anatomy of the chest wall, which you just don't usually see in an adult or a child. This kid's in trouble and he needs to be put on mechanical ventilation. Pause Adobe Presenter and take a look. This completes part 1 of Clinical Anatomy of the Thorax. Please remember that materials presented in this presentation are often the property of the respective copyright holders. In this case, many of the images belong to the publishers of the TEMA Atlas, Lippincott, who publishes the Rowan's Atlas, and Toltec, who publishes the VH Dissector. Copyrighted materials can be used for educational purposes, and only 1 copy per student is permitted for educational purposes, and redistribution is not permitted.